நான் யூஸ் பண்ணதில்லை. கேன் யூ அட்ஜஸ்ட் இட்?
இல்ல நீங்க இதுல பிரஸ் பண்றீங்களா இல்ல ஃபோக்கஸ் மட்டும் வச்சா?
ஃபோக்கஸ் மட்டும் வைக்கிறீங்களா? எனக்கு அந்த லூப் சைடு கொடுங்க. யா மேக்னாவா? ஐபிடி அட்ஜஸ்ட்மெண்ட் இதுவா? பெர்ஃபெக்ட். லைட் போட்டா சில டைம் அங்க 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 ரொம்ப பிரைட் ஆயிடும் கேமரால. இல்ல இது இது பெட்டரோ இல்ல? நல்லா இருக்கா? அப்போ இதை எடுத்துடலாமா? இந்த you don't need this, right? Gloves. Am I audible there? Okay. Blur ஆகும். இதுல வச்சிடலாமா ஃபுல்லா? So somebody should have done an index for this. இது பண்ணிட்டு இண்டெக்ஸும் பண்ணலாமா? அது பத்தியும் லைட் பாடி டிபி பிளேட் 15 ஹேண்டில் ஜஸ்ட் கீப் இட் ரெடி. சீக்ரெட் போடலாமா? இன்னும் கொஞ்சம் விசிபிலிட்டி. Okay. Okay, am I audible there? Am I audible there? All right. So this patient has a severe discoloration. So we're going to do a preparation to mask his discoloration. If you see today, we are just going to do the preparation for 2.1, 2.2, and 2.3, and that's for your understanding. And if you look at his occlusion, cutting it. You will see that there is enough clearance for 2.1 and 2.2, right? And here there is a slight overlap. I would not suggest a veneer on this because at MIP he is getting a direct hit of over his porcelain, or at least at the porcelain tooth junction. So to avoid that, we can always do a ortho combined veneers by just slightly tipping this or tilting this, rotating this tooth a bit outside, and then we can plan the preparation. With ortho, you can also reposition this canines at the lower, but that we would do it later. Now the plan is to prep. For demonstration purpose, I'm going to prep 2.1, 2.2, and 2.3. And the birds that we're going to use is DM305. This is from Mani. So this is a 0.5 depth cutter. So if I'm taking a 0.5 depth cutter, on the presentation I was talking about DC21. That's from SS White. It's the same bird which has a 0.5 depth cutter. So this is Mani's 0.5 depth cutter. Just that Mani is a bit expensive compared to SS White. So this is more of a subtractive case. It's not an additive case. We need to prep more on it, but I'm going to show you an ideal preparation over this. the plan is I will prep this. You guys are going to do this later and do do it today or another day. Today itself, no? You will have time. Because what I thought I will do a temp also and show them. The company, I call him another day and do the other side. Alright, so secret tractor. For visibility, I am just using a secret tractor. Right. Alright. So, as I told you, this is my depth cutter which I am going to place first in his mouth. 0.5 depth cut is what I can create on the label aspect. So, I would start 1.5 to 2.5 away from the gingival margin. This is a very long tooth. You see this? Just going to run it from here. Water. Laser karanga, because aakada white karanga, right. Good. Now see the angulation. At one angle, I'm just creating the cervical depth cut and the middle depth cut. Just tooth runs. Don't keep preparing onto that. So you make a mistake when you keep doing it. Ideally, to mask his discoloration, we need even more preparation. We need more thickness of the veneer. So what we are planning to do is get the thickness more onto the porcelain and just do a 0.5 preparation on the tooth. So overall, we will have a 0.7 thickness of veneer, which will be slightly embossed, but we can just change the color, right? Alright. And now at this position, just to check whether I am exactly 0.5, I can tilt the patient to the side. And just see if I have engaged it well. I don't have a space. My polished surface is coming exactly in contact to the tooth. Okay? So it's exactly here. Now, laser white karanga Lokesh. Okay. Yogesh. Okay. Yogesh, laser karanga. Vali idu ka kuch aur Yogesh. So now I'm just going to keep the center depth cut as a fulcrum and I'm just trying to slightly reorient the burr. Why not rotating? Oh, sorry. It's a third, yeah? So, I keep this as a fulcrum and I'm just slightly tilting it. That's it. So, my depth cut of 0.5 millimeter is done. Okay, just two angulation. One, try to get it to the burr. Burr go down. Yeah. One angle and the second angle, and you just run it. Alright? Now, for the incisal reduction, I would need at least 1.5 millimeter incisal reduction. Now, let me say this height from here to here of the depth cut is 1 mm exactly. Okay, so this will be 1 mm exactly. So, my idea is to have 1.5 for a bit of incisal translucency, what the technician can give. So I would just run it flat. Now see this, we have 1 mm, I want to go slightly more than 1 mm, another half of this. So roughly this can be 1.5 mm, okay? If I have this 1.5 mm of incisal reduction, it's ideal for my technician to add a bit of material and then go ahead. I need pencil, sharp pencil, doctor. Yeah. Take a sharp pencil and mark the depth cuts, also the incisal. Alright? Now, let's go to the lateral. Again, 1.5 to 2, 2.5 mm above the cervical. I'm just going to go 1. This is 1.1 mm. A little more, 1.5. Alright? So, I've done the depth cuts for this, and you mark it. Alright. So now, my canine. Cutting it, okay? Cutting it. Right. Open. Canine, again the same thing. You're just gonna go. Open button. Slight angulation for this incisal depth cut. See this? Now it is perfectly engaging. It has to engage exactly to understand. Now I'll just slightly tilt him a bit. I want the canine's labial shot. Okay. Okay. So now with veneer preparation, we are actually getting or just copying the tooth anatomy altogether. So let's say the incisal edge of centrals and laterals both are flat. So we're just making a flat incisal depth cut. But when it comes to canine, I cannot make it flat and make it straight. No, there'll be a lot of dentin exposure or even pulp exposure at times. So in a condition like this, what I would do, I'll have to place my depth cuts on for my incisal by angulating it perpendicular to the mesial slope and also perpendicular to the distal slope. Check the slope. That's how I will follow the anatomy. Now see this, just go here. 1, a little more, 1.5. Now when we will just connect these two, that will be the plan. So to connect this, you can use any diamond burr, blue ring diamond burr to just connect them, or even your depth cutter you can just use to connect. But only thing is your depth cutters are a little expensive. You might, you don't want to keep changing them. Okay, so in this case I am just using a depth cutter. First thing I would do is the incisal reduction. Okay, so you will do the incisal reduction first. So now we have done the incisal reduction. I need some incisal refinement here. I can still use the disc at last, but before that, sorry, correct? Out. incisive reduction is done till you don't see the pencil marking. Now I still see this bit of pencil marking, but anyway I'm going to use the disc. I can rounded it, and your cuspal anatomy should not be too sharp for the canine. You have to slightly rounded it. Alright, so you just slightly rounded it. Now this is my TR26F. I'm going to start from my central. My central is not straight. I can straight on. Okay, so now you have a gap here, you don't have a gap here. Okay, so let's see how we deal this space and how we deal it here. Usually, as I said, I would not prefer to open the contacts. I always want the contacts to be intact, because when you have an intact, contact, you will have, the patient won't have a foot infection, and at the same time, the technician will know how to end it. He will know how to place it exactly at the contact. So now see this, I will do, my motive is only to do the label reduction without preparing the gingival margin. Most mistake what people do is, you will start running it like this, for the margin. Don't do that. Always see, my motive is only to remove the pencil marking, okay? See, in this discolored cases, usually after you prep it, your stump shade can be little better. So that's an advantage. Okay, so you can even just restrict with 0.5 or always bleach the case, wait for 3 weeks and then do. Bleaching also is a very good option for this. 1, 2 and 3. You can see I did a kind of 3 plane reduction. Plane reduction is done, and now we will work on the margins. Now when I am working on the margin, I make sure I am not going more than 0.5 the thickness of the burr. Now see, when I am going to do the proximal margins, only the tip of my burr will contact. See that? If the tip of the burr contacts, that means I am made of finish line of 1 mm. If my whole surface contacts, it make it 1.5. It gets too aggressive. Now when I prep, you can see the value is getting better. So, you don't have a very dull color. So, it looks like most of his discoloration is more superficial. You can achieve good shade selection match for this guy, even at 0.5. Alright, so one finish line is done. Let's go to the knee here. I'm doing my proximals. You will see this step that is created. You shouldn't have that. So at the end with my disc I will work on that. Okay, so there's the incisal roughness. Now see this, you shouldn't have this sharpness over here. Open. Taranga Babish. You know the bag or disc? Somebody have it? No, my bag. Did I get the bag here? Or? Yeah, my laptop bag. Suction please. See the color, no? I told you, now the preparation, what thumb shade you have, that will determine the most. Huh? At the same time, your margin should follow the papilla. Otherwise, you will see a tooth triangle here and that will be exposed. And say there should be a side, I just want my disc, get that box out. Now let's go to the lateral. Second, open, notice. Quadrangle மட்டும் கனெக்ட் பண்ணிருங்க. There is a quadrangle handpiece connected to the micro motor and I have a disc. Yeah, in that, just connect that. Open. Now if you see here, there is a space here. This is the same way you even treat for diastemers. So I would not just do my finish line here. That is at the peak of my papilla. Let's say this is the peak of my papilla. I can just draw the finish line, but I wouldn't do it this way. I would try to take it as palatal as possible because I want my veneer to actually go inside so that it will have a better emergence profile. Okay. And at the same time, I want a labial path of insertion. So if I see it straight, I should be able to see the finish line. But my finish line goes as parallel as possible. You can also make this a wingless finish line when it comes to the distal, but it all depends on how your technician can blend the porcelain to that. If your technician is not that skilled enough, if you do a wingless, it would not blend well. So that's how it is. Now we will go to the canine. Again, the canine has a spacing here. So I would prep the canine's mesial as palatal as possible. Okay, wherever you can, get it as palatal as possible. So I'm going much behind. And you can also go subgingival here. I always prefer to go subgingival wherever there is a spacing because I get a better emergence profile. So we will go a bit subgingival here, suction. Retraction cord. So usually if I have a retraction cord, what I would do, I will pack the cord and prep it equigingival. So to pack a cord and prep it equigingival, it is almost like I have done a subgingival preparation, particularly only on the mesiogingival aspect. Okay, the labial is still equigingival. Okay, so only this area goes slightly subgingival for a better emergence. Okay, so the preps are done. Here I taken it inside, here I taken it inside. This is at the contact. So now we're just going to refine them. I don't want all these sharp angles. I don't want sharp incisal edges. I don't want this line angle to have a step. We're going to just smoothen all of them. This is after all the preparation. Now if you see this, my canine is still looking straight, correct? And I have a bit of discoloration here. So what I would do, I would slightly angulate this a bit. So I'm trying to get this third plane reduction at my incisal third. Okay? What we're doing here is a button preparation. I'm just doing a flat button preparation, no incisal overlap. I don't prefer an overlap because there's a study which is proved. So that's the overlap technique which we were doing for many years, and this overlap, what they proved is that incisal palatal step, on that area when you have a very thin porcelain, that can chip off over a period of time and can lead to micro leakage. So we just prefer to just have a flat button preparation. And cutting it, see, I still have discoloration here, so I need a proper communication to my lab so that he should understand that there is a bit of discoloration here, and he would mask it accordingly. Even inside the porcelain, on the intaglio surface, they can add a bit of masker. They have an opaque masker which can be added on the intaglio surface section and also mask that discoloration. It's all a bit of lab's work. All your job is just do a good preparation, a smooth preparation, and give it to the lab. And now we'll just refine it. No proclamation. If you want to correct it, see, okay, now okay, so I'm just going to show you Bonalpha. If you do a lot of proclamation reduction, he will end up with sensitivity if you don't have a good ideas. Okay, simple for a proclamation reduction. This incisal third, we go more angulated. And the height, I will reduce another 1 millimeter more. So if I have more of incisal clearance, let it be labially as well as incisally, my technician can move the veneer that much inside. That's all it is all about. Okay? So I don't want to reduce more. We have to then do unlimited dentin sealing and okay, so now you can see this elevation is unnecessarily going to make my porcelain also too thicker over here. So I can flatten that. So when you dry the tooth, and can you close the water? So for final refinement, I would run it in dry mode. Better if you can use a yellow ring at this stage. A yellow ring will just give a better smooth finish. Okay, so you shouldn't have that step. I want a smooth transition. from the margin to the tooth. So again here, now see this step, I don't want this, so we will just lightly. Again, open, location, open button. Alright. So here, when I have a lot of discoloration, always I would prefer to have more clearance so that my technician can mask the defect with a good porcelain thickness. So. Now, finally, we just smoothen it. I use a disc. This is a Soflex disc from 3M, and this disc, or you can use any disc, doesn't matter. I am making the button flat. I would prefer the coarse, but use it at a slow speed because we are not going to polish or do anything. We are just trying to round and all this. So I need this that will remove a bit of tooth structure. These sharp angles have to be removed. You need a nice smooth preparation. Over here, see this? I'll slightly open up the embrasure there. And remember, now the contact is really tight. Now what happens when it goes to the lab, this tight contact, when you take an impression, your technician is going to do a dissection and he will cut open this contact. That will again cause a misfit in your veneer seating. So ideally, if a technician can do the dissectioning from the, by placing the cast upside down, he comes down and he exactly stops here, the two modules separate. But most of these guys, what they do, they will just try to slice through. You will have a massive misfit on your veneer. So what you can do to just facilitate for your impression making and for your technician, you have a proximal strip or something. You can just run it as normal composite proximal polishing strip, which is a coarse. Which brand do you have? I guess get whatever you have. You just run it inside with a very fine one. I just want to create a small separation, but it will not look like it is created. Okay?
Can we use matrix band?
A band will, a thin band, okay, yes, you can do. If you are using something like a Palodent or something that is really thin, you can actually create a slight separation. You can't use IPR strips. IPR strips will open it up too much. Now you see almost here itself, I can see you should be able to just run a nice floss easily. Even a floss also, you can just try floss on it. So meanwhile, we will just smoothen it. Open button, open, yeah. And one more thing, a little bit of dentin exposures if you have here and there, even if you don't do IDS, you can get away. It's not going to compromise on the bond strength that much. But if you have a massive of one third of, your complete incisal edge or your cervical, it's better to always do a immediate dentin sealing. Kusuda?
Okay.
Okay. The anesthesia is going down. Okay? Actually, we don't need. Now, can you see that there is a nice, slight natural gap there. So I don't even have to open it. It was just some plug that is, kind of covering up. This more slight space that you see will facilitate in your impression making, and also your technician can, fabricate a nice veneer. So this is how your prep will go, and now we will temporize it. Yeah, thank you. So, will you wash பண்ணிக்கோங்க, or can you shift it to this index? How to make the putty index சொல்லிடலாமா? Or it's getting too late. You can't do overlap. You do only button. Yeah. Don't do overlap. Overlap, no, you can do, but you will have to circulate. Yeah. It goes too much, You are, in overlap, you are always reducing more. You have a lot of unsupported, porcelain overhangs, and there is a high chance of chipping off. Okay. Okay, so he's asking me, when do you open contacts, when you don't? So I would always not open the contacts. I will open the contact only if I have conditions like class 3 defect. Let's say I have a class 3 defect here. I want to open it up. I will completely remove it, restore it with composite, and give a wingless finish over here. And on the day of bonding, I will reactivate that composite with a, with a cojet or aluminum oxide 30 micron, and then we will bond it. So if you have a class 3, I will do number 1. Number 2 is if I have a black triangle. Post-ortho relapsed cases or some patients, aged patient, if they have a severe black triangle, I will open it up completely. That case. Another condition where I want to distribute space. Now let's say this is too narrow. I don't have space over here. I want to distribute the space and get this lateral look a little more wider. So I have to break open contact here. No, only then I can give more width to this. So distributing space. Next, if I have a cant, midline cant, let's say the two centrals are lightly tilted. So I will open up the contact, create a space, and then I will restore both the veneer. I can position it however I want. Diastema, yeah, already your contact was broken. So do we have time for that, or they will all wait? என்ன பிட்ட போறாங்க? Prep margin கொஞ்சம் கான்டாக்ட் வரும்போது what happens is you will hit the gingiva. You can gingiva touch பண்ணும்போது உங்களுக்கு சில டைம் bleeding stimulate ஆன்லைன் ரொம்ப கேர்ஃபுல்லா நீங்க பண்ண முடியல பண்ணலாம். You have even small diameter discs. I use those discs sometimes. அந்த மார்ஜின்ல லைட்டா நீங்க ரன் பண்ணலாம். vigorous smooth margin. Okay, and very important, this incisal edge has to be bit straight. If you ask me this incisal edge, the distal, I can see I'm working in a different angle. So if I look at it in 12 o'clock or a straight angle, I have to open panunga. Okay, I have to straighten it. From 12 o'clock we will be able to see. Okay, that's what we say. And it should just be parallel to this. And remember, the height of the preparation of the canine central should be equal. Canine central should be equal. And canine angulation, we're doing a smile design, canine to canine. The axial inclination of the canine also should be tapered, should rightly angulated inward. Otherwise, what happens? Let's say your canine is tipped outside. The whole veneer is everything is going to look proclaimed. You don't know why he is making it so proclaimed. One of the canine would be lightly tipped out. Everything will be proclaimed. So next step is we have to temporize him. Let's say I've taken an impression. Now I have to temporize these three. We have his model. In his model, we can take an index, preoperative model. You can even do if you want to do a mock-up transfer, you can add wax onto this. Okay, and you can then take a putty index of that and then transfer it. Can we shift it here? Just focus panam. Yeah. Okay. Yeah, I think I need light body, and there are so much undercuts here. Mask panna mudiyuma? You have a flowable or something? Can you quickly get me a flowable or a wax or something? Your model should not have these kind of undercuts. So in that case, if you're doing making an index, it can tear over there. Okay, so let's see if I can block it. Block. I want to just block it. So the more than wax, I think a global composite will do. Pick up an end. Thinner than 0.7 light care. Thicker than 0.7, we'll go for dual cure. So any overlay, onlay, inlay is dual cure only. Dual cure adhesive with bonding agent. Okay, so otherwise you can go with. But now if you look into Pascal Magnus theory and all, literature will always say you have to use light cure for everything. That is something which I'm not able to adapt to it, but what they say is everything you have to use a heated composite. Composite is 70-degree mel, you can heat it. Restorative composite can be used for bonding. That's how literature will say. Okay, but when we have conventional products, and I've been using for how many 15 years, and I don't have a problem. So I wouldn't recommend all that. I was heating each composite every time, and bonding, you won't finish a bonding process. It takes even more time. Yeah, dual cure will have this tertiary amines, these amine derivatives will cause discoloration over a period of time. It will change color, so you can't go for a dual cure. That's why if it's a thicker restoration, dual cure changes color, it doesn't matter at all. But when it's a thinner restoration, dual cure changes color, it will go.
Ceramic integration is pre-treatment.
You have to do it. Very clear. So I'm just blocking the undercut. So I just move it out of the light. Some undercuts here. I put some flowable. Okay, so இது mix பண்ணல. You don't have that injectable gun இருந்தா வேற பத்தி இருந்தாலும் பரவாயில்ல. Okay, you mix it for me, somebody. The gun is already. We need a light body and a putty so that you can get fine definition. First, one person is going to mix the light body for me. We are using the Dentistry Sirona as light body, right? What is the putty? Aquacell putty again from Dentistry. So we just going to make an index of this teeth. Yeah, you mix. A person mixes there. Yeah, you mix. And I want you also to start with it slowly. You do it slowly, you fix faster. The light body is getting mixed a bit faster. Yeah. I'll take it. Thank you. So all I will need it is mainly over the incisal and the gingival. And the putty is ready, and I am just placing the putty over it. Can you see I'm not giving a lot of pressure, just giving a bit of tap onto it. I need more thickness on the palatal aspect, okay? So I'm tapping it on the labial. Okay, see, if you see this, the index gets more thicker onto the palatal compared to the labial. Labial, I can't make it too thick because I have to transfer it into the patient's mouth. It shouldn't fill up in between the lips, right? So, just going to be It's a little uneven, but it's okay. It might take a bit of time to set. Okay. So we're going to give it some time, and then we're going to remove this.
Is there anything to be considered for endodontically treated tooth preparation?
Yeah, if you're doing an endo-treated tooth, if you want to plan for a veneer on endo-treated teeth, you have to make sure. See, the thing is, you cannot go more on dentin. You can't do unlimited dentin sealing on a non-vital tooth, right? So you can, but the bond strength is not going to be great. So in that case, you have to try to be on 90% enamel. Okay, 90%. If you know you have enamel on that, in that case, you can go for a veneer onto an enamel, and also on a non-vital tooth. Other than that, you have to look into the discoloration. If it's discolored, you will have to do a non-vital bleaching, change the stump shade, lighten the stump shade, and then wait for 3 weeks and then prep and then bond, because you have to wait for 3 weeks for the oxygen to be liberated completely, and then go for the final preparation and bonding. Otherwise, you will not be able to bond properly. So, that is one thing. And again, finally, you don't know whether you have done a good endo. The previously, if it's an endo treated teeth, I would always suggest you to redo the procedure, redo the endo, make sure done a proper irrigation, follow the irrigation protocol. If you don't want a discoloration because of a little bit of pulpal necrotic tissues remnant inside, so got to be sure with your irrigation protocol, and also shear the GP below the orifice. So if somebody else has done the endo, I would not go for a veneer. I would prefer to do a veneer if I have done the endo, so that I can shear GP below, do a proper obturation, and then go for a proper entrance filling with a higher value composite, and then go for a veneer. And also, to be on the safer side, instead of going for a low opacity or a high translucent ingot, I would go with a medium opacity or medium translucent ingot. This is one instruction I give my technician. Because when it is medium opaque, in case you have a slight discoloration, it will block. And finally, it has to be not less than 0.5, for sure, because if it is less than 0.5, if there is a discoloration, it will be seen through. Enamel, all on enamel, 0.5, medium opacity, ingot. This is very important for a non-wet. It's going to take a bit of time. It's a little sticky.
Zirconia Emax
When you're doing, I would not consider zirconia as a veneer itself, because zirconia is not a bonded restoration, first of all. Nowadays they say you can improve bond strength by air abrading zirconia and all. That's only you can improve bond strength, but you cannot match it as you does lithium disilicate. When it comes to lithium disilicate has silica. Zirconia does not have a silica in it. Zirconia is a zirconium dioxide. So you cannot etch it. For a porcelain bonding, when it be bonded, you have to etch it with hydrofluoric acid for 60 seconds, at least 9% hydrofluoric acid, 60 seconds, and I would suggest an ultra-dent one. So when you are etching it, you are abrading all the silica out of it. So only if it is a lithium disilicate, you will be able to abrade silica out of it. If it's a zirconium dioxide, you cannot abrade silica out of it. It will still be the same opaque color. On a lithium disilicate, once you treat it, you will see, when you dry it, you will see a very nice frost inside, no? That means you have removed some silica out of it, and it's ready for some resin to penetrate inside. Correct? So only lithium disilicate I would consider it as bonded. Zirconia, see, with zirconia you have to improve the bond strength by treating it with alumina, 30 micron alumina. You can air abrade inside, use a zirconia primer, and then you can then use MDP based resins and then bond it. But still the bond, you cannot bond it. I would say you can just improve the bond strength, that's it. Okay, now we have the 15 blade. Let's try to cut it off. Yeah, so now what I'm going to do, I'm going to, I think this is 11, no? Okay. Ideally it would be 15, huh? We can use 15. Okay, remove the putty from the undercuts first. slightly remove it slowly from all the undercuts, and now this is how the index is. Okay, so now you don't need the model, or yeah, we can keep the model ones on the side. And now first thing is I will have to cut out the excess around the gingival margin. Let's see how I'm cutting the excess. Now see this, I place one cut like this, another weak cut, around. So this is how we'll do the contouring around the, exactly, you got to be very close around the margin, because you don't want to have a lot of excess and it's going to be very difficult for you to remove it on that day. Now take it around, go inside, and another release cut, and see this, you get this cut around the canine gingival margin. Now we're going to go here and see this cut is as close as possible to the lateral. Now for the central, again I go around as close as possible, and let me be a little faster. This is the same index technique that you will do even to take a index of your mock-up. If you have done a mock-up on this model, or if you have done a resin print, out of that you can just take an index the same way. Alright, so we have done made the silicone putty index. Take a pencil and always draw the midline, because now when I'm taking it into the patient's mouth, I should know how I'm orienting it, right? So that will be a challenge. Now let's go with the patient. Now the plan is we're going to call him another day for the remaining preps. Open etchant, have an etchant now. Or gauze, gauze or cotton. See, your preps have to be smooth, because, and at the same time, a technician is not going to put a spacer in between. Spacer is going to create a lot of, you just need an ideal space. Naturally, when they fabricate the veneer, you will get a very minimal space that is more than enough for your porcelain. So make it as smooth as possible, no undercuts. The porcelain has only then will fit so well onto it. So what I will do, when I am going to do a temporization, I will check whether the fit is correct or not. Okay, so place it here, check the fit, yes, it's perfectly fitting around the margin. Okay, what do we have here? We are using apdch crown. This is from what is this brand? Something new. Oh yeah, Avu brand. Now yeah, they have this Avu core and all. Yeah. So this is this acrylic material that they are using. This is a 10:1 gun, I guess. Yeah. So we are just going to spot etch. Now I want this temp to bond onto this. I'm just going to temporize him. Usually what I do in my practice, I place Teflon tapes in between, interproximally, Replace Teflon and then put the temp so that you won't have excess in between the margin into the gingiva. Just keep it away from the patient eye. I'm just getting one drop in the applicator, please. Irka? This is a spot etch technique. I'm not going to etch the full surface because it's going to be very difficult for me to remove the temps on that day. So this temporary is going to just bond onto this spot etched area. No adhesive. Some people prefer to put a spot bond, but I would not because I want an easy removal of this without an anesthesia on that day. Because when I'm doing a veneer trial, I would not prefer to numb the patient because I want the patient to smile and check how the the veneer is on there. So 15 seconds and then you wash it off. Suction please. To check whether you're on enamel or dentin, you have to run your probe to understand whether it is enamel or not. This is all enamel. You can get a screech here, all enamel here, but here and there, I think here it is enamel. Here somewhere I would be in dentin for sure. You could have done an IDS here. Okay, now this is etched. Now what we do? Can you cut it in small pieces? Yeah. Now place these Teflons in between so that it's easier and make sure that the temps don't flow interproximal, So protecting the papilla. Give me one more. All right. So we fill this up. Extrude a bit of material outside. Hope it doesn't penetrate. Yeah. From the base outside, from the base outside, from the base outside. Mostly on the labial. Okay, I fill it up and open. Just seed it in. See, the pressure we give is just labial, just hold it onto this. And you have a tweezer, you can just hold on to this and bring it here. Okay. What to wait for a while. Check how it is setting. Now see, the reason why I cut around the margin is I don't want to have a lot of excess all around here. So it's easy for me to just remove it towards the end. And usually always use a nice material. I would always go with a Pro Temp or something like that. This also stains badly. And that's also important. It has to be a little durable till the patient comes in a week, right? See, it's not setting up a bit here. We just got to wait. This sets in a concept called as a shrink fit. It's a shrink fit setting. So once it shrinks, it will fit well against the tooth, and into the undercuts, it's just getting bonded. Okay. So we wait for a while. Yeah, this is setting okay, but I need to give 5 minutes for the material inside to set. You just can't take it out immediately. So this is kind of setting. Let's check how it's getting hard. This material can take some more time is what I feel. It's pretty flaky compared to the good branded ones. It's a little flaky, okay? So wait. The good brands are, I would say, ProTemp. You have Cool Temp from Colteam. ProTemp is 3M. Then you have Temp Smart from GC. These are good. Yeah. Before I had placed the temp, if you had a stump shade there, take a shade or take a picture. Always a picture to coordinate with the lab. Before prep, after prep. So after prep, if you have a stump shade and a preparation picture, the technician will know how to mask this. So if he knows there is a discretion way to mask, how to go about it, everything he's going to decide and work accordingly. Okay?
Temp shade.
Temp shade, see the thing is you have many shades. A2 standard is what all the companies have here. You also have B1, but I think in India it's not available. Sometimes I've requested 3M to usually give me B1 and all. Initially they had, nowadays they don't have. Some patients they want to do a mock-up trial and they want to know how a B1 is going to look on them. I will try a B1. Some of them usually they will say I want B1, I want bleach, I want to have very white. They don't understand how white it is. So put a B1 and you ask them to see the mirror and they will freak out. Oh, it's too white. So that's when you can understand the patient is not for a real white. But some patients are there who want really white. You know, I've had even Indian patients who will request, I want bleach white, and white is not enough. Arabs usually will prefer a real white color. It's all different, ethnicity and their choice matters a lot. Indian colors, usually A1 is always ideal. A1 is enough and most of our patients are happy with it because they want a natural veneer and they don't want anyone to know that they have got veneers. No, that's a... Okay, now I'm just going to remove this. When I take this off, this is just temporized. Alright? Open banana. Okay. Now let's say you have some defect here and there. Like for example, I can say I have a small chip off here, right? Take a flowable, fill it up like your cure it. So if you have some chipping off and here and there, you can just add on and a little bit of flowable and then. And one more thing, your patient comes back the next day, you will see it all in turmeric color, it will become yellow color. It's because it's unpolymerized layer on the surface. The surface is unpolymerized. Okay? And one more thing, you will have so much excess at the barrel. Open. Material is so thin. Usually it is not so easy to remove. That's actually a task. When you try to remove it, ProTemp, you can't remove it that easy. So you leave it some more time, it will actually set. Maybe it's taking a lot of time to set. Because as I told, the superficial layer is not polymerized. Okay, so you have to always remove the unpolymerized layer by using a disc. have to sit and polish or do so much work. Just remove the superficial layer and send the patient. Getting me? Yeah. So now you can actually understand that with a thickness of 0.5, I am able to get a little bit of better value. So 0.5 veneer thickness will actually work in this case because his stump is not discolored. So with this easily you can understand how it works. This is already a very high translucent material. No? Now porcelain, imagine you go with a medium opacity and 0.5, you can block this. So you don't have to add more thickness like how we thought initially. Alright, so what's the plan now? Huh? Yeah. What about the hands-on? They will do it now or after the lunch? And no. Alright, so we'll break for lunch and then do the hands-on. So, question lunch ka do na? Doubts are there.